If you've seen posts saying the Depo shot causes brain tumours, here is the straight answer. It is not. Most women on Depo get a tumour or meningioma. The risk goes up on paper. In real numbers, it stays uncommon. Hi, I'm Dr Sylvia, an NHS GP and women's health doctor. In the next few minutes, I'll cover what a meningioma is, what higher risk actually means, who this matters more for, what the UK and US authorities are saying, and exactly what to ask at your appointment. Then you can decide with a clear head. First, language. When people say brain tumour here, they usually mean a meningioma. That is a growth in the lining around the brain or spinal cord. Most are not the aggressive cancers people picture when they hear brain tumour, but they can still cause problems if they grow and press on nearby structures, so we take them seriously. The Depo shot, also known as Depo-Provera, the contraceptive injection, Depo-medroxyprogesterone acetate, delivers a strong, steady progestogen dose that lasts about 3 months. That high, continuous progestogen exposure is the part of the story that's under scrutiny when we're talking about the risk of meningioma. You're going to hear two words a lot: association and relative risk. So here's what they mean. Association means in large groups of people, those who use Depo for longer show up with meningioma diagnosis more often than people who did not. It doesn't automatically mean Depo caused my tumour, the way a broken bone follows after a fall. These studies can't run a perfect experiment that proves the cause in one person, but they provide a useful flag, not a direct cause-effect relationship in every instance. Relative risk is the multiplier, the number that drives the social media and news reports. If something is about 5 times higher or about 2.5 times higher, that number sounds huge because it's comparing two groups to each other. Absolute risk is the one that decides what your next steps should be. And that is saying, out of a large number of women, how many extra cases are we actually talking about? Let's consider a simple picture. So imagine a risk that starts very small. Think single figures per 10,000 women in some of the published framing, and multiply a tiny number by 5, and it's still a small number. That is why clinicians keep saying the headline multiplier is real enough to make us cautious, but the everyday chance for most users remains low. 2 pieces of evidence dominate the current conversation. We're talking about 2026. A large French case control study in the British medical journal BMJ, Roland and colleagues in 2024, looked at progestogens and meningiomas that needed surgery. For prolonged use of injectable medroxyprogesterone acetate, that's the Depo shot, the odds were in the region of 5 to 6 times higher than in women without that exposure. There's a really important clinic nuance that we should discuss here, because even in a study with many meningioma cases overall, the number of women who had actually used injectable Depo was small. So the signal, and by that I mean a clinical flag that tells us we need to take a closer look, is strong enough that regulators paid attention, but it's not proof. It's still not proof that every long-term user is in danger. The next study is a large US analysis in the Journal of the American Medical Association, JAMA Neurology, by Zhao and colleagues in 2025. And they found Depo users had about a 2.4 times higher relative risk of meningioma diagnosis compared with matched controls. That rise clustered in women with longer use, think beyond 4 years, and in those who started or used it in older age groups, roughly over 31 in that data set that they studied. The authors' number needed to harm sat around 1 extra case per roughly 1,150 users in their modeling. Now, that is a statistically important signal or flag. Clinically, it means there is still a high number of Depo users who do not develop meningioma before we get to one extra meningioma case. Most users never get a meningioma. So put together, duration matters. How long you used it matters. Age matters. A single injection, 2 or 3 shots is not the same conversation as somebody who's been using this for 5 or 10 years of jabs. This is why you are seeing more noise online, news, blogs, social media, and so on. In the US, the FDA updated the Depo label in December 2025 to warn about meningioma risk with repeated, mainly long-term use. That applies to the standard intramuscular shot and the subcutaneous version that's given underneath the skin. What doctors are advised to do: 1, counsel patients on the association or risks. 2, watch for concerning neurological symptoms. 3, if a meningioma is diagnosed, stop the Depo. In the UK, the College of Sexual and Reproductive Healthcare has issued public-facing and clinical responses as this evidence keeps evolving. And so here is what we doctors are saying to our patients. 1, the overall chance stays low. 2, most people do not need to change contraception purely because of the headlines. 3, the injection sits amongst methods where a slightly higher risk is discussed, especially with long-term use. 4, and if you've ever had a meningioma, that's a different conversation. You need to contact your GP, your clinic, rather than trying to manage yourself. That is the clinical bottom line from both the research and expert institutions. So, raise the priority for a proper review if any of these fit you. You've used Depo for several years, especially back-to-back use past the long-term window the studies flag. You're in an older reproductive age band where the US data showed more of the signal. You have a personal history of meningioma, or you are under follow-up for one. You have new or changing neurological symptoms, a headache pattern that is new for you and it's persisting and getting worse, changes to your eyesight, hearing changes or tinnitus, ringing or buzzing in the ears that is new, seizures, unexplained weakness, or changes in your personality, thinking that is out of character. These symptoms are not a meningioma diagnosis, but they are a reason to be assessed properly and even urgently if they develop severely or suddenly. Please don't stop Depo in a panic without a plan. Stopping also has its own issues, bleeding problems, hormone changes, risk of pregnancy if you still need birth control, and so on. Now, I've got a full video on what happens when you stop after taking it for years. I'm going to link it in the description so you can have a look at that. Do book a GP review if you are uneasy, using Depo long-term, have symptoms that you're worried about, or you just want to rethink your method. Good contraception counseling is always about benefits, risks, your priorities, things like bone health, bleeding pattern, if the injection suits you because of privacy, using it for endometriosis pain control, your future pregnancy plans, so many different things. And it's not about an isolated headline out of context. If Depo is still the right method for you after that discussion, then continuing to use it with your eyes open is a valid choice. If it's not, you switch the plan. Keep the appointment simple. Try saying something like this: I've been on the Depo injection for X number of years. I've read about newer research on meningioma risk and the updated warnings. Can we review my total use of this shot, any red flag symptoms, and whether another method would fit me better now? If you want a structured way to walk into that appointment, use my free contraception guides, the questions to ask, the method comparisons, how to prepare so you leave with a decision and not feeling more confused. I'm going to place the link to the guides in the description box for you to click on. Next time, I'm covering heavy periods after stopping hormonal contraception. Check out the link below. Drop your questions as well, and I might answer that in the video. Before you go, if this calmed the noise around meningioma risk and the Depo shot into context and numbers you can actually use, type risk in the comments so I know this video is doing its job.